Good morning and welcome to the third meeting of the Health, Social Care and Sport Committee in 2026. I've received apologies from Elaine Whittam and Paul Sweeney for today's meeting. Jackie Dunbar MSP will be joining us as a substitute member of the committee. The first item on our agenda is for the committee to decide whether to take items 5 and 7 in private. Do members agree to take these items in private?
Agreed.
Thank you. The second item on our agenda is to take oral evidence from a second panel of witnesses on the draft climate change plan and its implications for public health in Scotland. And I welcome to the committee Jane Miller, Programme Manager, Health and Social Care Alliance Scotland, and Dr Joanna Chewton, Health Improvement Manager, Population Health and Climate Change, Public Health Scotland. And we'll move straight to questions. And Emma Harper.
Thanks, Convener. So there's loads of questions that I might have, but I guess I'll just kick off with the first question is, are you aware of any health impact assessments that have been carried out in relation to policies covered by the climate change plan? And if so, what were the findings? And if not, what do you think they could tell us or would tell us?
Take that, and thank you very much for the opportunity to contribute to this session and for the committee's scrutiny of the climate change plan. We think climate change and our response to it is a key public health issue, and so very keen to engage with this. So there have been several impact assessments on the climate change plan, and I don't have the detail of those the impact assessments, but we have been contributing to some of that work around the potential health benefits and health risk, and there's quite a range of health benefits across the whole of the climate change plan, across all the sectors, through buildings, transport, green space, food, but also potential risks, as you point out, and potential inequalities that need to be considered. And so from a public health perspective, we're really keen to work with colleagues to look at undertaking health impact assessments. We think they're really important in terms of the design and the delivery of plans, and so sort of welcome the work that's been done so far by Scottish Government on that, and would support ongoing work of that.
Okay.
I'd also like to just sort of add as well, just to recognise that climate change has such a disproportionate impact on particular groups, including disabled people, people living with long-term health conditions, and unpaid carers. So I think we would definitely welcome that equalities angle as well in terms of those impact assessments, just to note that there is that disproportionate impact and that it won't be felt equally, and to think about that kind of wider lens in terms of addressing health inequalities and taking a kind of structural approach as well.
How does climate change disproportionately affect people with disabilities or carers?
It disproportionately impacts in terms of both directly and indirectly in terms of health consequences. So flooding and heating will have a really sort of disproportionate impact on older people, for example. The risk of death with heating with older people is quite significant. In terms of, as well, costs that are associated with kind of climate action, in terms of disabled people are maybe for their conditions or long-term health conditions might need to have kind of more access to energy and heat, and that will also have an impact in terms of costs. And we know that the cost of living can have also a disproportionate impact on disabled people and people living with long-term health conditions. So there's a kind of multifaceted way that climate change can really sort of disproportionately impact those groups.
Okay.
To that, I think some of the similar principles apply to policy responses as well. So our policy responses can disproportionately impact different population groups across disability, socioeconomic status, gender, all of the protected characteristics. So as we design and deliver the policy responses, such as retrofit in housing or active travel routes, we need to think about designing and deliver those policies with health and equity in mind, and working with communities and with the evidence base to ensure that we anticipate any of those disproportionate impacts, any of the potential health risks associated with them, and maximise the health benefits associated with them. And we have examples, for example, in the transport sector, where we carried out a health impact assessment on the Just Transition Transport Sector Plan and made recommendations. So we were able to identify some of the potential risks across population groups, as well as the determinants of health, and make recommendations to support policies and the delivery of plans which would mitigate those risks, but also help to maximise the benefits that can be accrued from policies.
Okay. It's quite interesting you're talking about, housing and transport, and people might not think that's specifically NHS or health, but it just shows you that the climate change affects all policies in all areas. And so does that mean that we should be considering health in all the portfolio areas? I know there's other committees that are scrutinising the draft climate change plan. We're doing it in rural committee right now. So to what extent could or should a health in all policies approach support climate change plan policies?
Yeah, sorry. Yeah.
Go first, Gord.
Yeah, absolutely. I think the committee is probably aware that most of the factors that affect and create good health lie outside of the health service. So around 80% of the factors that influence our health are in the places we live, work and play. So things like transport and housing and food and income, good quality jobs are what we refer to as the building blocks of health. And the climate change plan cuts across all those areas, and therefore we need to be thinking about those as determinants of health. So if we can create policies that are reducing emissions but also maximising health benefits, considering potential risks to health and equity in the design and the delivery of those policies, then they're going to produce good outcomes in terms of emissions reductions and meeting some of those very significant health challenges we have in Scotland, in terms of low life with very low levels of life expectancy and health inequality. So absolutely, we would, from a Public Health Scotland perspective, very much welcome a health in all policies approach and explicit recognition that the climate change plan is a massive opportunity to contribute to improved health and reducing health inequalities in Scotland. Sorry.
Just to say, I would also agree in terms of actually viewing climate action as a kind of way of preventing ill health and in terms of addressing health inequalities. Also as well, I think we would also want to recognise the role of social care in terms of that kind of wider picture as well. In the terms of climate discourse, social care is often quite neglected, but actually is a sector which really does contribute to emissions, but also is a way of addressing those impacts as well in terms of sort of serving people in the communities. So I think we would just want to kind of recognise the role that the social care sector plays in that kind of wider picture as well in terms of climate impacts. And I think it kind of goes back to the point around health inequalities, and actually if we take that preventative approach, actually we will reduce emissions, which will then have a kind of healthier society, and that people's rights will be kind of forefront as well.
Okay, thank you. Thanks, convener.
Sanders Gohani.
Thank you. Declaration of interest as a practising NHS GP. Thank you very much for joining us. What would be the how much money would it cost to decarbonise the NHS estate?
I don't come from a perspective of NHS facilities. My focus really is on the public health perspective on the climate change plan, so I wouldn't be able to answer that question. Sorry.
Okay. Well, so many of our hospitals and NHS buildings are crumbling. We have a £1.5 billion maintenance backlog, and that isn't just an abstract concept. It means unsafe hospital buildings with rack or water ingress. It's an ageing electrical supply, which might not meet modern electrical standards and equipment, failing heating systems, outdated mental health facilities. These are basic needs of patients. And as we've seen at the Queen Elizabeth, contaminated water costs lives. So surely we need to fix the basics before spending a lot of money on the decarbonisation of the infrastructure.
Yeah, as I say, I don't come from a health facilities perspective, so I'm not able to respond in terms of the decarbonisation of the health service. I guess from our Public Health Scotland perspective, our focus is broadly on the sort of the determinants of health and the role that decarbonisation of housing, heating buildings and transport, food, the economy will have in terms of improving health and health inequalities. And I perhaps suggest that NHS Assure, who are national NSS, who take a lead on the decarbonisation of the health service, would probably be able to provide a more helpful response to that than I'm able to give.
Okay. All right. Given that the theme that we're on is all about NHS emissions, I think it would be worth moving on given the answers that were received.
Thank you, and perhaps committee can write to NSS with some of those specific questions that you want an answer for there, Sandish. Carol Mockin.
Thank you, Convener. I'm interested just particularly in active travel actually, but other things to do with decarbonisation around transport. I just wondered if you were familiar in your public health role just with how much energy the NHS is putting into facilitating active travel for people to get to appointments and for staff, etc. Excuse me.
Just as a sort of point of clarification, when you say how much energy the NHS is putting into supporting active travel in relation to the NHS, is that what the question was? How much are we working to do that?
How hard do you think we're working to sort of get those aims?
So I'm not as involved in working with the NHS estate. My focus is broader on the population health work, but the NHS have the NHS Climate and Emergency strategy, which sets out how they're going to deliver decarbonisation in the NHS, and a part of that is in relation to travel and carbon and emissions from the fleet, but also patient, staff, and visitor sort of perspective, and have been working. I am aware that there is a programme of work which is looking at that does take a public health perspective and is working to link up health boards with local, regional transport groups in order to develop ways of enabling sustainable travel through from communities into healthcare facilities, and that there are good relationships between health boards and local and regional transport services. We would like to see a greater focus on the reduction of transport poverty within that context. We know that there are inequalities in terms of access to sustainable transport generally, but also in relation to accessing NHS services. So it's something that is being taken forward, and lots of hospitals have active travel plans and are working on that. And again, good relationships between NHS Assure, who lead the NHS facilities type work, and all the territorial boards in relation to that. I'd also say we have a partnership group between colleagues working in the transport sector, both in local authorities, but also boards and third sector with public health, so that we're able to support and share learning around the delivery of sustainable transport options that will help to address inequalities, transport poverty and maximise health benefits.
I mean, it's very important, you're absolutely right, because I do hear from people, particularly rural poverty and the lack of transport, so we do need to do some stuff on that. And recently I had staff contact me because in rural areas, if you start a shift at 7 o'clock in the morning, you cannot get there unless you drive, and they just wanted me to raise that. So a really important points if we do really want to change this around. I don't know if anybody else wants to come in. It's harder online, sorry.
I would also say as well that transport policies need to be designed in a way that doesn't disadvantage certain groups as well. So just kind of highlighting that car usage might be required for some disabled people or for sort of social care workers as well within their role. So and particularly again sort of within that rural context. So just to say that when sort of transport policies are being designed, that actually need to make sure that we're engaging with people that might be impacted as well in those design of those policies, and that if there are any financial implications, that they are also resolved for those individuals that might be impacted. We did some work in 2022 with Disability Equality Scotland and the Mobility and Access Committee for Scotland. And we did highlight that within sustainable travel plans, disabled people and those delivering and receiving care can be impacted. So just to make sure that a diverse range of groups are really involved, including in active travel infrastructure, so thinking about people with visual impairments as well and how they might be impacted. So again, it's just kind of going back to that rights-based approach in terms of the way that we're designing and delivering climate action policies.
Thank you. I wonder if there's anybody on the panel that would be able to answer the question around the amount of mileage that, because my questions are directly on transport, mileage that are undertaken by staff now, and whether there's a plan or a programme to look at how we reduce that or maximise if people are travelling, how we do that in health and social care. I don't know if there's anybody on the panel that would be familiar with any of that work.
I'm not familiar, only for my own organisation, Public Health Scotland, that we, undertake, and I imagine other health boards would, travel surveys to understand patterns of travel for staff and design their transport. Public Health Scotland, that we have done that and will be working to develop plans based on that to support the use of sustainable transport, so a shift over to supporting public transport use, active travel use. Obviously car use is necessary, and particularly in rural areas, but encouraging that shift to reducing car kilometres and increasing uptake of sustainable transport modes.
Lovely, thanks. I appreciate your answers, and that's me, convener. Thank you very much.
Sanders Gohani.
Thank you. So yesterday, with First Bus, I launched the first 24-hour bus route, the number 77, which goes from Queen Elizabeth down into the city centre, through the West End. It also goes out to the airport. So what that means is that staff working late get to use public transport if they are living along this extensive bus route. It means patients. So obviously you don't get sick between 9 to 5, so they're able to come in to hospital using the bus route. But given that this is the first, do we need to realign our working timetables to fit in, especially late night, to fit in with public transport routes? And do we need to have a further focus, given that public transport is so important at decarbonisation, on getting these routes into major sites like the Queen Elizabeth, like the Royal in Edinburgh, in Aberdeen as well? There's a major carbon dioxide use that occurs up there. So would that make a huge difference?
Absolutely, access to health and social care facilities through sustainable transport is vital for many reasons, not just from a carbon perspective. in Public Health Scotland, we did have done quite a lot of work recently on transport poverty, which is about people not having access to reliable, accessible, safe, available transport, and we know that that transport poverty can limit people's access to services, as you've outlined, and the need to develop transport systems that meet those criteria so that people can access services. But we also know it's not just about a transport system. We need, obviously, from public transport, it's important that we have a frequent service that goes to the right places and is safe and accessible. But that's also linked to spatial planning, where we design and deliver our services so that they're joined up and that these systems take into account. People work shifts, people have, like you say, patients don't only get sick between 9 and 5. And so I think working together across health and local transport and national transport, as well as spatial planning and service provision, then we can develop a system of sustainable transport that supports the net zero agenda, but also supports access to health and social care facilities and is good for the population's health because it is encouraging a reduction in car use and greater active travel because of the first and last miles often associated with public transport and the benefits from reducing air pollution. So, really an extensive potential implications and impacts from something like that, the bus route.
I would also sort of echo as well the point around the interconnection. So in terms of making sure that any transport or bus routes people are able to access the services that they need. I think in particular as well that we know that women are more likely to use buses and transport, particularly for kind of short multi-journeys to sort of aid caring responsibilities, and health and social care will be kind of included within that. I think also as well just that kind of wider picture around making sure that people are able to actually access buses and transport. So from our perspective, we know that disabled people and people with long-term health conditions actually being able to get to transport can be challenging in terms of the infrastructure in local communities. So not having drop curbs, pavement kind of infrastructure, sort of the challenges of actually being able to get to transport before being able to then access health services is also something that needs to be taken into account. So I suppose it's that interconnection again and that kind of wider planning picture that we would also emphasise in terms of transport as well.
Thank you.
Harper. Thank you. Thanks, conveners. Just a supplementary about carpooling, car sharing. When I worked in California as a nurse, I was a member of the carpool team, and you got points, and then that led to prizes and incentivised you to, share a car in Los Angeles because it was a very choked up city with lots of vehicles. And there are a number of NHS boards that are doing some type of carpool schemes now in car share, so sharing electric vehicles and things like that. Is that something that we should be encouraging more? Not necessarily points and prizes, but encouraging people to car share more. And one thing I did notice was that NHS Dumfries and Galloway's appointment letters had advised people to show up 15 minutes early so they could get a parking space, instead of maybe the reverse of the appointment letter saying you could take number 9 bus route or you could do this cycle route for your appointment type thing. So should we be encouraging more incentivisation like that, like carpooling and other modes of transport to get to hospital appointments?
I would say yes, absolutely. Encouraging, giving people information, providing options that are alternatives to car use. Those are great ideas. And I like your suggestion about rather at the bottom of the letter, rather than saying come early to park, actually saying what these options are. So I would agree with you.
I'd also kind of add as well, just thinking from a social care perspective, I suppose that switch to electric vehicles, but just to note that I suppose within social care, a lot of people that are professionals are actually using their own vehicles. So I suppose there's a bigger picture as well in terms of supporting staff as well, in terms of being able to have more carbon low emitting options too.
Yeah, I know that East Ayrshire Council, Eddie Fraser, when he gave us evidence, they use electric cars for the care workers, and that was something that I think was welcomed by the staff. That's it, thanks.
Gillian Mackay.
Thanks, convener, and good morning. Scottish Care responded to the Scottish Government consultation on the draft circular economy strategy in January 2026 and stated that without targeted support to achieve this vision, care providers will struggle to implement circular practices effectively, risking further service reductions and loss of choice for individuals who rely on care. So what further support is needed for social care to ensure it can meet targets for waste reduction and embedding circular practices?
So we worked with Scottish Care in 2022 to do a series of roundtables looking at climate action in the context of social care. And from our series, we made recommendations, and one of those was for the need for a climate emergency innovation fund for independent and third sector organisations. And we kind of proposed that this fund would enable providers to take those meaningful steps in terms of climate action, such as improving energy efficiency, adopting sustainable procurement practices, and investing in greener technologies. So from our kind of perspective and Scottish Care's perspective, it was really about making sure there was that appropriate funding for social care, and just the recognition that within discourse around climate action is often very much a neglected sector, and also just to kind of highlight that the role that sort of the social care workforce can play in terms of creating green, sustainable jobs, and for ensuring that they're actually part of that kind of just transition piece. They were in the Just Transition Commission, there was the recognition of the role that sectors like health and social care can play in terms of supporting the economy, providing jobs, but also that kind of greener piece as well. So we would just also advocate that the sector is valued in terms of the contribution that it makes in terms of climate action, but also that the workforce within that are kind of supported through pay and conditions as well.
A number of health professional leadership bodies led by the Royal College of GPs and the Royal Pharmaceutical Society have written a manifesto for health and climate, and this calls for urgently accelerating the electronic prescribing programme by allocating appropriate resource. Does the panel have any thoughts about the impact this could have on NHS sustainability? And I wonder if I could go to Joanna first on this.
Yeah, as I said to the other MSP, my sort of focus isn't really on the health services, so I'm not as well briefed around that that agenda. So unfortunately, I would point you again to other parts of the health service that might be able to answer that better than me.
That's great. Thanks, convener.
Myrtle.
Thank you. Good morning. I just want to stick on the theme of waste, and I'm going to focus on food waste. There's a significant food wastage in hospitals. I think it's over 50% in some hospitals, and the procurement policy actually for some of the major hospitals allows for food to be procured south of the border, packaged and driven up the M6 every day. So I just wonder whether we've had a look at that particular issue, given that food waste is such a huge has a huge impact on climate change.
Again, I can't talk to the health sort of service as an estate, but perhaps make some general points around that. I agree food waste is a big contributor, you know, both from an NHS point of view, but more broadly from the population, and reducing food waste will not only reduce emissions but also have implications in terms of disposable income and from a cost of living point of view. What I would say about the NHS is that it is a significant anchor institution within local communities, and therefore, from not just from a waste perspective, but from a procurement perspective, we would a lot of the NHS. A lot of work has been done in the NHS as an anchor institution to use its procurement power to source food locally and to use local suppliers and to sort of invest in the local community in terms of getting food for the NHS, which has benefits beyond net zero. It also has benefits in terms of community wealth building and an investment back into the communities. So as a general point, that role of the NHS as an anchor in relation to food is an important one.
No, I accept that the NHS should be an anchor, but what I'm saying to you is it isn't when it comes to food procurement in a lot of cases. And I think more concerningly would be the impact that has on the health of patients, given the quality of food obviously not as high as it should be, given more than 50% of it is thrown away. So I'm back at this. If they are supposed to be an anchor institution, why are they not? Or who has the power to make sure that they are then?
Again, I'm not working directly with the territorial boards, but as Public Health Scotland have a programme of work supporting a progression framework on anchor institutions, which is working through with the health boards around how they move. I imagine that boards are at different stages in terms of working as fulfilling those anchor institution duties, but there is work ongoing. I don't know in particular in relation to the food sector, but more generally, and I imagine that's part of that procurement process that is ongoing, but I can't really comment on what's currently happening within the NHS.
No more questions.
Emma Harper.
Thanks. Is this supplementary about medical gases? Is this the one you want to make? Okay, cool. Thank you. So I'm interested in, as a former theatre nurse, I'm interested in all the changes that they've done, medical gases, green theatres, all of that. And then I was involved in learning about the change in the gases or the propellants used for inhalers, for the multi-dose inhalers, and thinking about getting people in the right inhaler. So I know there are changes to the propellants for the multi-dose inhalers. Is that something that is happening, I suppose, fast enough? Is that something, because I know there are concerns about the propellants used for the multi-dose inhalers contributing to climate emissions?
Again, as I'm not in the NHS, I'm not involved in the sustainable healthcare, so I am aware that those, as you say, those changes have been made. And I think you took evidence last week where one of the witnesses was talking that Scotland was doing really well in relation to that, but I don't have the detail around that side of the NHS. My focus is more on that population health side of the work. So again, an organisation such as NHS Assure would be in a stronger position to comment on something like that.
Okay.
Sorry.
Okay, thanks.
Joe Fitzpatrick.
Thanks very much, Fiona. I want to explore a little bit about engagement and communication, both with the health and social care sector and with community. So maybe, first of all, looking at the sectors, do you feel that there's been good engagement with the health and social care sector in developing the plan? So, Jane, do you want to?
Yeah, I suppose from this perspective I'm speaking of is around sort of the social care perspective. So I think there needs to be a stronger emphasis on engaging with the sector around the climate change plan, the implications, because buildings, transport, waste, they all have an impact on sectors like health and social care. So I think there's maybe a lack of awareness around the impacts of the plan are around for that sector. So I think, yeah, definitely there needs to be also accessible communication around climate change, climate action, and what that means for people on a kind of day-to-day level within their roles, within their jobs. Definitely as well, there needs to be an emphasis on the impact on the individuals as well. So ensuring that any low kind of carbon options are actually really person-centred. So making sure that people's rights and needs and preferences when they're receiving and delivering care are really at the heart of a lot of the kind of conversations, and really the importance of individual choice. So just that small example around plastic straws obviously being kind of a sort of sustainable option, but actually that had a significant impact for disabled people. So just an example like that low carbon options, or the kind of the bigger piece, we really need to make sure that we're ensuring that people that are impacted, including staff as well, are really engaged in this process. And we would advocate for any engagement using the 6 principles of inclusive communication, just to ensure that everyone is able to participate in the conversations around climate action and sustainability.
Thanks. I'll come back to you more on the individual point, but do you want to say a little more?
I think as I mentioned, the NHS have a climate and sustainability strategy where there is, I think, good engagement across the climate health care agenda in terms of how the NHS will deliver on the climate change plan across the sectors, as Jane has mentioned, around heating and car use and procurement and the other sections of the climate change plan. And there's a clear governance structure around that in terms of oversight of that process and engagement and working with relevant sectors in order to support the delivery. So I think at that level there is good communication. I would support what Jane said around communication being sort of accessible and ensuring that the low carbon options are understood and the benefits beyond greenhouse gas emissions reductions are clear. We know from the evidence that health and cost of living benefits of a lot of climate actions have a lot of salience with the general public. And so there is sort of a strong move around a sort of benefits first for many of the actions that we're taking both in the health service and out with the health service to reduce emissions. So
so that was the area I was keen to go into next. Is that personal benefit? There's pros and cons, but often we just hear the challenges of making the effort. It's too hard to cycle. It's the LEZ zones are just too restrictive. I can't get to my shop. So how do we make sure that people can understand the benefits to them? We heard last week that it's looking really good in terms of the health benefit from the LEZs, but I still get constituents complaining that this is really restrictive. They can't run their business, but then you go back to them and say, look, it looks like this is saving people's lives. Children are not suffering lifetime breathing conditions because of these actions, and so actually we need to be doing more. How do we make it more relevant? All of the things like cycling, just all the health benefits that also have a benefit to the climate. How can we make sure people understand the benefits to them? Jane, do you want to go first?
I think it's really about engaging with people and also involving them in the decision-making process as well, because once people are involved in that decision-making process, they're much more likely to be invested. And it's also the kind of the wider connection around climate action, obviously reducing health inequalities, but actually around the role that plays for people's rights and their human rights. So I think it would definitely be about engaging with people. So I think you mentioned like the LEZ zones, making sure that disabled people were really involved in being aware in the design and the potential implications, if there's going to be an implication for them, that they've been involved in that and that there's mitigation measures. So I think it's really about that engagement piece, but making sure that it's done in a really accessible way. So that's why I mentioned the sort of 6 principles of inclusive communication, because you need to make sure that there's that that everyone's really being engaged, everyone's being able to participate, and that they are aware and understand about the potential benefits, but also are involved in the design process as well.
Yeah, thanks.
Yeah, I would completely agree with that. I think there are a number of points really. I think we need to think about how we frame some of this. As I said, I think there is an increasing recognition that the health and the cost of living benefits of many of these things are important. So, we've done thinking about framing public messages in other areas. So in public health, for example, we talk very much about the building blocks of health as a way of explaining how we get good health. And I think there's work that's been done around framing how we think about some of the climate actions so that we are thinking about them in relation to the benefits for communities. Completely agree around the need to engage with communities, to understand issues, to create solutions together. We have a very strong emphasis both in health and in the climate world on place-based approaches. There is often a lot of synergy. We're dealing with, for example, transport systems. We want to create transport systems that are healthy. We want to create transport systems that are low carbon, and we want to create transport systems that are equitable. And we can bring those things together if we work with communities and use the tools that we have, such as Place Standard tool with a climate lens, which allows us to look at these. If we do health impact assessments, which allows us to understand and anticipate potential disbenefits and inequalities. I think we also need to recognise that information alone is not going to change people's behaviours. Everybody doesn't always have the capacity or the ability to act on information, so you often will see an inequality in terms of being able to do that. So there are structural things that we need to do to work with communities to create solutions which make the low carbon healthy options more accessible, available, the easy options to do. So I think working health and sector teams working together around the areas which affect health and the climate is a really important thing that we need to do in order to get that behaviour change in effect.
Thank you. I was going to ask you about place-based planning, but I think you've covered it, so thank you very much. Thank you, Convener.
Thanks. I'm keen to hear what more government should do to align health and social care budgets and their carbon budgets to help them to reduce their emissions and meet emission targets. So I'd be keen to hear your thoughts, Dr. Chilton.
Yeah, I mean, I can talk about that from a preventative perspective, and I'm sure the committee is aware the new population health framework puts a refocus on or a renewed focus really on the prevention agenda, and I am aware that work is being done with the Scottish Government in terms of that preventative spend and tracking and thinking about how that goes forward. I think there is something important from a governance point of view in Scottish Government around early engagement between health on the climate agenda and climate on the health agenda, to look about how we can understand the cost savings from climate action from a health point of view. So we know that not doing anything has massive cost implications. We know that climate change is going to, currently is having an impact on the health of our population, and that will get worse, and therefore taking action to reduce emissions is obviously a part of our prevention agenda from a health perspective, and will have cost savings. But as we've talked about these co-benefits for health from climate action, will also have cost savings for the health service as we move forward. So I think alignment between the population health work and the health service reform and the climate agenda is really important to maximise those benefits.
I think from our perspective as well, a clean and safe climate is a human right. So we would advocate for human rights budgeting, just in terms of like raising, allocating, spending resources to meet these emissions targets, but also looking at that kind of wider piece as well around gender budgeting, particularly related to social care, and the wellbeing economy as well. So just taking that kind of broader, holistic view when we're thinking about budgeting and spending.
Okay. Brian Whittle.
Thank you. Just on the sort of the budgeting and whatnot. I mean, one of the issues we have with the NHS is the huge use of plastics and the like. Do you know, is there any work being done around how we tackle that particular issue? Because that's one of the biggest problems we have in terms of climate change in the NHS.
I'm sure there is. Again, because I'm not sort of linked to NHS Assure who are doing that work, okay. I don't have that. I'm really sorry. I don't have that
okay.
that information to hand.
No problem. Okay.
Emma Harper.
Thanks, Convener. It's just a quick question. We're talking about population health, and I know this session's about emissions reductions and things that we can do, but we had Professor Gregor Smith here talking about climate change impacts, but pandemic planning for the NHS and the impact that that has. And we know that people with disabilities, health inequalities, may suffer more disproportionately for climate impacts, but also I'm thinking about disease management. So we are seeing mosquito-borne avian influenza, for instance, or other mosquito. Not saying that avian influenza is mosquito-borne, but we're just seeing that the climate change is causing disease issues, zoonotic diseases, and we know that there's maybe an impact for humans. So is that part of the population planning for the future in the impacts of climate and then disease management?
So I suppose on two levels. So the UK Health Security Agency do a lot of work on the impacts of climate change, including the impacts in terms of vector-borne disease and zoonosis, and they published the most, I guess, the state of the evidence around that a couple of years ago, the Health Effects of Climate Change report. So, you know, we have a bit of a sense of where that's at currently. In addition, the Committee on Climate Change do the risk assessment technical report, which also sets out the position in relation to those impacts and in relation to not just the climate impacts, but the implications for health. So we have that evidence base. The latest technical report is due out next year, so that work is being done, and I'm aware that health is sort of quite a significant part of that. In Public Health Scotland, we're beginning to look at some of the data from Scotland in terms of the impacts of climate change on health outcomes, and so beginning to work that's started to be done around heat-related or temperature-related mortality, you know, I think that in a position where we're considering, you know, what that in that wider surveillance piece around, we do have a Lyme's, Lyme's disease surveillance programme in Scotland, but supplementing that with other ones is something that is in consideration. So, I mean, absolute points that these things need to be thought about as we move forward, and will be determined by the extent to which we reduce emissions, because that will have an impact on the actual climate impacts, which then subsequently have an impact on health.
Okay.
The witnesses for their evidence this morning. The committee will write to relevant stakeholders on the other information that you weren't able to speak to today. And I'm going to briefly suspend the meeting for a changeover of witnesses. The third item on our agenda is consideration of one affirmative instrument, the Scotland Act 1998 modification of Schedule 5 Order 2026. This is a draft statutory instrument which requires approval by resolution of the Parliament before it can become law. In this particular case, the instrument also requires approval by both houses of the UK Parliament before it becomes law. The purpose of the instrument is to provide for a limited exception to the list of reserved matters in Schedule 5 of the Scotland Act 1998 in respect of the identification and regulation of substances and devices for use in assisted dying. This is being made in the context of the Assisted Dying for Terminally Ill Adults Scotland Bill, and I welcome Liam MacArthur, the member in charge of the bill, to our meeting. This order enables the Scottish Parliament, subject to certain limitations, to confer a power on the Scottish Ministers by way of subordinate legislation made with the agreement of the Secretary of State to identify substances and devices for use in assisting a terminally ill adult to voluntarily end their own life, and to confer a power on the Secretary of State to regulate such substances and devices by way of subordinate legislation. The Delegated Powers and Law Reform Committee considered this instrument at its meeting on the 13th of January 2025 and made no recommendations in relation to the instrument. However, it did agree to write to this committee and to the Scottish Government with further questions about the order. We will have an evidence session with the Cabinet Secretary for Health and Social Care and supporting officials on the instrument, and once we've had any questions answered, we will proceed to a formal debate on the motion. And I welcome to the committee Neil Gray, Cabinet Secretary for Health and Social Care, Gerald Byrne, Head of Constitutional Policy, Nicky Crossan, Assisted Dying Shadow Bill Team Leader, and Ailsa Garland, Principal Legal Officer, Scottish Government. And I invite the Cabinet Secretary to make a brief opening statement.
Thank you very much. Good morning, colleagues. Thank you for inviting me here today to speak about the Scotland Act 1998 modification of Schedule 5 Order 2026, and also for considering this order in such a timely manner. As the committee will know, following Mr MacArthur's Assisted Dying for Terminally Ill Adult Scotland Bill passing the Stage 1 vote in May, the Scottish Government committed to engaging with the UK Government to try and resolve the legislative competence issues identified with the bill. Work has taken place at pace to fulfil that obligation and to lay this order ahead of the Scottish Parliament's Stage 3 considerations so that members are free to make their decisions based on their own convictions and those of their constituents rather than on whether or not the bill is outside of competence. This Section 30 order is the result of that work, although it must be noted that it only goes some way to resolving those issues, and there will still be need for a Section 104 order or other measures to resolve the remaining issues with the bill. The details of that order are still being worked through, bearing in mind that a Section 104 order is only laid in the UK Parliament after the royal assent of any bill. It was with that in mind that we opted to focus our attention on the Section 30 order in the first instance, given that it also needs to be laid in the Scottish Parliament and it is therefore time-bound by the dissolution of Parliament for the Scottish election later this year. The Section 30 order modifies Schedule 5 to the Scotland Act 1998, which defines reserved matters for the purposes of that Act. It gives the Scottish Parliament limited competence to legislate in relation to the identification and regulation of substances and devices for use in assisting terminally ill adults to voluntarily end their own lives. This conferral of competence is time-limited, in that it only extends to provision contained in an Act of the Scottish Parliament which results from a bill passed before the 7th of May 2026, meaning only Mr MacArthur's Assisted Dying Bill. This was felt by both the Scottish and UK governments to be appropriate, given that both governments are neutral on the issue of assisted dying and do not therefore feel it would be right to preempt any future legislation brought to the Scottish Parliament on this issue should this bill not pass the Stage 3 vote. Whilst the order enables the Scottish Parliament to confer a power on the Scottish ministers to identify substances or devices by way of subordinate legislation, the committee will note that this must be done with the agreement of the Secretary of State. Similarly, the order enables the Scottish Parliament to confer a power on the Secretary of State to regulate such substances or devices by way of subordinate legislation. I recognise that these are slightly unusual provisions. However, the UK Government was extremely keen that UK ministers retain a role in the overarching regulation of medicines and devices, given that this is a reserved matter, as they felt that this would be the best way of ensuring continued regulatory consistency across the UK. It should be noted that, whilst the Section 30 order makes the necessary provision for the Scottish Parliament to legislate on the identification and regulation of substances and devices, at this point in time the bill itself only includes provision for the identification of substances in Section 15(8). It would need to be amended to include provision for the identification of devices, mention of which was introduced into the bill at stage 2, and for the regulation of both substances and devices. The inclusion of provisions around the regulation of substances and devices is to allow the Medicines and Healthcare Products Regulatory Agency, the MHRA, to have a role in this, and the committee will note that Kim Leadbitter's bill also includes provisions for this. However, I must be clear that exactly what that role would look like has not yet been determined. I'll now turn back briefly to the Section 104 order, although I recognise that this is not the focus of today's session. As members may have noted from my 16th December letter, proceeding by way of a Section 104 order would require the bill to be amended to remove provisions from it, which would then be dealt with through the 104 order after royal assent should the bill pass. That removal of provisions would be necessary to bring the bill within competence before the Stage 3 vote, as if the bill is passed outside of competence, there is a strong likelihood of it being referred to the Supreme Court. With that in mind, MSPs should be similarly mindful of the need to ensure that no new provisions are amended into the bill at Stage 3 which take it further outside of legislative competence. I recognise, Convener, that the challenges that this poses for MSPs, particularly given the importance of the areas being discussed for removal, namely provisions relating to the regulation of health professions and to employment rights and protections. However, this Parliament has a duty to ensure that any bill passes is within competence, and I hope that the committee has found that information helpful, and I welcome any questions, Convener.
Thank you very much, Cabinet Secretary. Sandesh Gohani.
Thank you. And a question of interest to practising NHS GP. Thank you very much for your statement. I do understand the Scottish Government is neutral on this, and I think it's really important that we see what's before us today is not about whether you are for or against assisted dying. It is to enable the will of the Scottish Parliament to be enacted should it pass. So with that in mind, I've got a few questions, if I may. With the Section 104, if we were to pass the bill at Stage 3, do you have an assurance and a guarantee from the Secretary of State that this will be laid in the UK Parliament, regardless of what happens to their assisted dying bill? And that would be something that would then allow this bill to progress.
Convener, I thank Dr Gohani for his questions and also his prefix to his questions. He's absolutely right that proceeding with this Section 30 order and the committee's consideration of it does not change the government's position of neutrality. This is about enabling Parliament to be able to take its decision based on the merits and the conscience position of individual MSPs. And it was a commitment that we gave earlier in the process that we would engage to ensure that that was done as best as we possibly could. Clearly, these discussions are based on an element of negotiation between governments. These are areas of reserve policy, so at the end of the day, they're the responsibility of the UK government. And their decision-making around which elements have been contained within a Section 30 or a Section 104 order are for them to determine. But Dr Gohani is correct that my understanding is, officials can correct me if I'm wrong, my understanding is that a Section 104 order would require to proceed regardless of whether there was similar legislation contained currently in the House of Commons or the House of Lords or not, and indeed whether that particular legislation passes or not. That this is a separate process based on the Scottish Parliament's processes.
But have they indicated sort of a guaranteed assurance they will do this if we were to pass?
Negotiations on that are still, and discussions are still ongoing as to the terms of what that looks like. But the fact that it goes into a 104 process, there will be assurances given around the UK government's role thereafter. But those discussions haven't concluded, so it would be unfair for me to give a categorical position right now when we're still discussing those elements.
Okay. And given the position that we're currently in, with the Section 30 and the potential 104 orders, are you and your officials content with the fact that it will provide everything that we need should the bill pass at stage 3 to become law?
Yes, although, as I say, the 104 elements are slightly more complicated because it will require some form of amendment to the bill in order for legislative competence to be complete. But I am certainly content with the Section 30 elements and giving us in this Parliament the ability to legislate on those areas that the Section 30 order covers. The Section 104 process, as I say, has still to run its course, and there will still be a requirement regardless of the conclusion of those discussions, for some form of amendment to the bill in order for it to be passed as competent.
Okay. And my final question is about unintended consequences. So medications, devices will change with time as medical expertise improves, and so things will change. Do these orders give us the flexibility to change the medications, devices as required? And also, are we content that these orders will only apply to medication and devices for assisted dying and nothing else?
On the second point, yes. On the first point, that's why the role of the MHRA, I think, is going to be important, because they obviously regulate and approve medications and devices for use within the health service. And so I think their role in being able to determine new or novel approaches will be important in the first point of Dr Gulhani's question.
Okay, thank you.
Gillian Mackay.
The potential 104 order, Cabinet Secretary, this Parliament can't formally scrutinise it in the same way that we can with the Section 30 order. So what does the Scottish Government propose to do to keep the Parliament as involved and as informed as possible should any 104 order come forward?
So, as I said, I thank Ms Mackay for her question, Convener. I think, as I set out in response to Dr Gulhani, the final decision-making around the decision as to why some elements are within Section 30 and Section 104, some are in Section 104, are more for UK ministers to respond to. However, for our part, I commit ourselves to continue keeping this committee and indeed Parliament and Mr MacArthur as updated as we can as to progress with those discussions and what the outcome of those discussions means for the progress of the bill. I think that's as much as I can probably say at this stage.
Okay, thanks, Convener.
Brian Whittle.
Thank you, Convener. Good morning, Cabinet Secretary. I suppose just really a point of clarification for me. I mean, I suppose I'm asking you, is the discussions around the sort of Section 30 and 104 around trying to limit any potential divergence should both bills pass, one in Scotland, one in sort of England and Wales? Is your intention to try and reduce that potential divergence of policy and the inherent issues that might incur?
Convener, Mr Whittle will understand that I'm first of all neutral on Mr MacArthur's bill. While I have met with Kim Ledbetter, the interaction there is not for me in terms of policy coherence. However, that's for Mr MacArthur to lead on, and however, I do know that the discussions with UK ministers on the routes that have been applied in terms of the decisions on Section 30 and the role of the Secretary of State have been in order to provide for some form of policy coherence. Now, there are various scenarios at play here. Ms Ledbetter's bill could fall, Mr MacArthur's bill could fall. They could both proceed. We don't know the outcome of that, and each Parliament has an independent process to go through that, and there is very limited interaction between the two. So again, it's for Mr MacArthur and Ms Ledbetter to, I think, answer the majority of the question there around policy coherence. However, as far as the discussions that have been had around legislative competence has been concerned, for which the Scottish and UK government has been discussing, I set out in my opening statement the fact that the Secretary of State's involvement is in order to provide coherence around the regulation of medicines and devices.
Thank you.
Emma Harper.
Thanks, Convener. Good morning to you, Cabinet Secretary. I think you've answered the question already, because there's ongoing discussions or dialogue with the UK Government. I'd be interested in, and that will continue until votes and decisions are made about the bill in the UK Government versus the bill in Scottish Parliament. UK Parliament, I should say. So I'm just interested to hear a wee bit more about the discussions that have taken place, and how will that proceed until, you know, decisions are made here in Scotland and then again in Westminster.
Convener, I thank Ms Harper for her question, because it gives me the opportunity again to set out the fact that these discussions have been taken at pace. I think colleagues with some familiarity with Section 30 orders that have been moved in the past, and indeed predictions around how these things can take time, will be aware that this has been a process that's moved at pace. It's been very constructive, and I'm very grateful to UK ministers and officials, as well as my officials, for the work that's been done to progress these matters at pace. I would expect a similarly constructive approach to be taken to the 104 process, and for me to be able to provide an update as soon as I possibly can to this committee and to members around the conclusion of the Section 104 discussions.
Okay, thanks.
Liam MacArthur.
Echo the comments the Cabinet Secretary just said. I said at FMQs last week, but I'm genuinely very grateful to the Cabinet Secretary's counterparts in the UK Government and the officials for expediting this process at pace. As the Cabinet Secretary says, there were many predictions about how long this process would inevitably take, and I think it is to the credit of both UK and Scottish Government that they've managed to reach this point, reach this agreement. I think the points that Gillian Mackay was raising are probably the ones that are of most concern to many colleagues going forward about the transparency of that Section 104 process. But it'd be helpful maybe if the Cabinet Secretary could confirm, my understanding is that Section 104 orders are a fairly routine mechanism for dealing with these sorts of issues. It'd be helpful if the Cabinet Secretary could confirm that's his understanding as well. But just reiterate the importance of ensuring that as we progress to stage 3, that MSPs are kept fully and informed on a timely basis on the progress of those discussions with the UK Government.
Convener, I thank Mr MacArthur for that. I'll bring Mr Byrne in a second on the constitutional elements, on the familiarity and the routineness of a 104 process. But I absolutely give that commitment that in terms of transparency, I have attempted to provide and furnish this committee with Mr MacArthur, with MSPs, with as much information as we can. We did that through the Stage 2 process, where we gave a critique of amendments and elements of the bill as it stood. And we will endeavour to do what we can to provide as much information as we can in terms of the question that he's raised there around the Section 104 process. But perhaps Mr Byrne can illuminate further in terms of the precedent here.
Section 104 orders are routine, perhaps not the right word, but they're certainly not an unusual part of the legislative process. If an act of the Scottish Parliament is affecting reserved matters, and there needs to be some consequential provision as a result of that, or to bring the bill fully into effect by changing reserved matters, which is the sort of category we're talking about here, and it's normal for the governments to discuss the need for a 104 order as a bill progresses through Holyrood here, and that's what's happened in this case, although alongside a Section 30 order. And as has already been observed, both governments have worked closely to address the legislative competence issues that have been identified by both governments in the bill as it stands. So I think that process is now well underway.
Could I also take the opportunity, thank you, that's very, very helpful, probably to reiterate the question I posed to the First Minister. I absolutely respect and understand the rationale for the government's position of neutrality. But I think as we saw through the Stage 2 process, there is a growing, I think, expectation amongst colleagues, irrespective of the positions they took on the bill at Stage 1, that the government will more actively engage in the amending process, even if only around technical amendments, to ensure the workability of any legislation that the Parliament were to pass. I know there's been ongoing discussions in government about that. Again, I think it would be helpful for the member in charge, certainly, but for the committee and for other MSP colleagues, if there were clarity around the level of engagement the government is going to be committed to at Stage 3.
Convener, Mr MacArthur is correct. Discussions are ongoing, and it would be my expectation to be able to advise colleagues as soon as I am able to as the government's intention for our approach to Stage 3.
Thank you.
And can I thank Cabinet Secretary for his evidence. We now move to agenda item 4, which is the formal debate on the instrument on which we've just taken evidence. Can I remind the committee that officials may not speak in the debate? Cabinet Secretary, can I ask you to move and speak to motion S6M 20226?
Moved, Convener. I've got nothing further to add.
I've had no indication from any of the committee members that they wish to speak or contribute to the debate. Does Mr MacArthur wish to put anything further on record?
No. Thank you, Convener.
The question is that motion S6M 20226 be agreed to. Are we all agreed?
Yes.
Thank you. The committee is agreed. And that concludes consideration of this instrument. At our next meeting, we will take evidence from the Cabinet Secretary for Health and Social Care on the Scottish Budget for 2026 to 27, and that concludes the public part of our meeting today.